Yes,
okay.
now we do.
You have it? Okay. Okay. So the first thing you see is that the submucosa of this descending duodenum is very fatty, okay? Very thickened and very fatty. It's like this. It's not a disease. Then, if you look at the centrum of the image, here, I will show you the region of the papilla. Okay, so look at this. I will turn, okay. Here. So here, you see this big thing. This big thing is the common bile duct, which is more than 15 millimeter. On the left part, you have the cystic duct, and on the right part, the hepatic duct, okay? And when you follow it, turning slightly clockwise, descending into the descending duodenum, I will arrive to the region of the papilla. First of all, I will region to the region of the ampulla. And here, you know, I am entering into the duodenal wall. You see, this is the duodenal wall, it's not the pancreas. And you still have the dilated duct. The duct is still visible, and you are into the descending duodenum. And now you arrive to the papilla here. Okay? So here, papilla, ampulla, ampulla, pancreas. Ampulla, 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 papilla. Okay. And you see that you have no tumor, nothing.
Yeah.
All this thing is strictly normal. So you can say that this patient has a functional obstruction, but not an organic obstruction. Functional obstruction means that he has been cholecystectomized already. We know that in 70% of patients with cholecystectomy, the diameter of the common bile duct increases with years. The second thing we know is that if the patient starts the gallstone disease by migration, for example, the risk to have a scar on the papilla after the migration exists, and you have more dilatation of the common bile duct after cholecystectomy in patients with previous migration. So second reason. Third of all, we do not know if this patient is using painkillers for, I don't know, arthrosis, pain of the chronic pain, and part of the population is using level 2 or level 3 painkillers, and it's also a cause of dilatation without any organic obstruction. And finally, the main thing is that you have the combination of no cholestasis, and normal EUS, and also, and I will show you immediately after, a normal papilla, because with EUS, you cannot see very well the papillary lesion. So you can miss, here you see the duct is less big than it was, you see? Because the bile has moved into the duodenum, and okay. So,
yeah, so
finally,
Dr. Palazzo,
it's obvious that this patient need nothing.
Yeah.
He do not need any ASAP, and the abdominal pain are not relative to that. Okay.
yeah, so Dr. Palazzo, there was no mass in your assessment at the ampulla, is that right? So, I mean, we can see it clearly, it's normal. But do you find any stricture? Because I couldn't find any stricture in the EUS.
Wait, can you hear me, Adam?
Yes, Imad. So,
can you hear me? So
I think it's completely normal.
Palazzo. I just want to make a few comments here on this case. This is not uncommonly seen in our referrals in the clinic where we have a dilated duct that is disproportionate for the age, because we have to understand that after the age of 50, you can add for each 10 years 1 millimeter dilation. The normal duct is 6 millimeter or less. That's the normal physiological dilation. However, there are certain conditions that are not related to any underlying pathology, including, as Dr. Palazzo mentioned, if you have a cholecystectomy performed, it is expected that the duct will act like a reservoir and they will start to dilate. Those conditions usually associated with no symptoms related directly to the duct, and usually the liver enzymes are within normal. And another thing that we were discussing, the analgesia and use of pain medications, that can lead to the dilation or the physiological dilation of the duct, maybe could be related to the motility problem. However, the one thing that you don't want to miss is basically coloductal cyst, especially type 1. Those patients can get risk of developing cancer, and that's why you may need to do ERCP. So in these patients, you may actually experience, they have some sort of elevation of liver enzymes. They may have experienced some sort of abdominal pain. And before all of that, they may have the gallbladder in place. They did not go through cholecystectomy. So that's a beautiful demonstration of a case where EUS is indicated when you have a dilated duct of unknown etiology or the diagnosis haven't been established. So please keep in mind, you have to look at the patient at 360 degrees, symptoms-wise, lab-wise, imaging-wise, and then you consider doing EUS for that.
You see here we have a normal papilla.
Yeah.
You see it? So we have a normal papilla, no adenoma. We have seen the ampulla itself with the bile duct inside the ampulla, which exclude an ampullary tumor. Intraampullary tumor never exists if you see the dilated CBD inside the wall, inside the duodenal wall, and we have to verify that the papilla is normal, and is that case here. So now we can exclude definitely the organic obstruction.
Sure. And if
So, Dr. Palazzo, just a
the
comment.
last thing I would like to say, if Prof. Palazzo would agree with me,
Yeah.
ampullary evaluation should contain both EUS evaluation, endosonographic, and endoscopic evaluation.
Yes, of course.
Yeah.
Of
So,
course.
so do you,
Yeah,
so I don't
endoscopy,
see
I'm
a
not
stricture, Imad.
endosonographer, so
Imad.
papilla and ampulla need to be seen endoscopically as well as on the EUS way.
Yeah. So
Okay,
can you hear
For
us?
this case, we conclude that the physiological dilation of the common bile duct due to cholecystectomy supported by the lack of symptoms
Yeah.
and the normal liver enzymes. Therefore, no intervention should be taken.
Yeah.
So, Dr.
we can
Palazzo,
Thank you
go
so
ahead,
much.
Hamad.
Dr. Palazzo, we used to do a lot. Dr. Palazzo,
Thanks. Thanks.
can
a
you
lot.
hear me?